morning. I'm Dr. Clay Cockerell, and I've got two talks I'm going to be giving you all today. The first one is about the accurate histologic diagnosis of malignant melanoma. And basically, we make melanoma diagnosis mainly with clinical features coupled with the histologic features. And most of the time, it's pretty straightforward, but there can be problems. And these are the main criteria we use in a standard case. We look for the low power features, breadth, usually greater than 6 millimeters, although they can be smaller than 6 millimeters, asymmetry, poor circumscription. The old caveat of any melanocytic proliferation on sun-damaged skin is melanoma in situ, especially in an older person until proven otherwise. In other criteria, we look for failure of melanocytes to failure to mature. They don't get smaller with progressive depth. Variability in the size and shape of the nests, presence of melanocytes at all levels of the epidermis, and then involvement of epithelial structure of next. And then, of course, these ancillary cytologic features, atypical mitoses, melanocytes that are atypical, and necrosis. If you see necrosis en masse in a melanocytic lesion, that's just almost pathognomonic of melanoma. So here's kind of a, quote, perfect melanoma, if you will. It's broad, it's asymmetrical, it's poorly circumscribed. You see all these single melanocytes beyond the nest of melanocytes in the dermis, a little bit of pagetoid spread here, a lot of pagetoid spread with this confluent atypical intraepidermal involvement with a mitotic figure there. And then the dermal involvement with both atypical melanocytes and nests in the dermis as well as the melanophages. And this is what that lesion actually looks like when we actually excise that. Now, how good are we at clinically diagnosing melanoma? Well, we're not that great. Studies ranging anywhere from 66% to 80%. It really never gets 100%. One of the best results ever was back in the 1980s at NYU, where the clinicians got about 82%. That was at an NYU skin cancer pigmented lesion clinic with Al Kopp and guys like that there. So we're not that good just in the general community. And in spite of all our A, B, C, D, E features that we use, we see melanomas that can simulate less serious lesions and more serious lesions that simulate melanoma. And here's some examples. These are a couple of melanomas that look a lot like a basal cell. Another one that was thought to be molluscum contagiosum, that white ring around the edge was because it had been frozen with liquid nitrogen. This one obviously looks like a pyogenic granuloma. That's kind of the classic simulator. And then this one looks like a solar lineage melanoma in situ. And this one looks like a seborrheic keratosis. And this last one was a junctional nevus simulator. It actually was melanoma. The patient actually refused to get this biopsied, and it eventually turned into a nodular melanoma and ultimately killed the patient. Now we get similar problems in histologic diagnosis as well, and I'm going to go through some of these for you in the remainder of the talk here. And these initially, let's look at lesions that are benign, but they look malignant, and these are situations where we get over diagnosis of melanoma. And so we don't want to unnecessarily hedge either. You kind of have to be like the three bears, not too hot, not too cold, just right. So you don't want to have somebody just always calling everything atypical needs to be removed, or call every Spitz's nevus a spitzoid melanoma, things like that, or atypical Spitz tumor when it's a benign lesion in a child. So, you know, there's a right way to do this, and it isn't just sort of formulaic, covering your rear end, so to speak. And so you have to know what these situations are. We can kind of run into problems. So one of these that we see a lot of times are these so-called site-specific nevi, where the lesions have some slightly atypical features. And these are some areas of common areas where we get these biopsies where lesions can look kind of abnormal. I'm not going to go through all of these. I'll show you just a couple of examples, but generally we see the melanocytes tend to have larger nests and a little slight pagetoid spread. And these are within the range of normal in these areas. In the ear, like this lesion, this was actually signed out as a melanoma. It was in a 21-year-old person. It actually, classically, these lesions kind of look spitzoid. They have these epithelioid melanocytes. They're often spindle. You may get a little bit of pagetoid spread. And this was not a melanoma. It was signed out as a melanoma, and the patient did fine. It was just conservatively excised and never really had any problems with it. But it's not good to carry around a diagnosis of melanoma when you're 20 years old. I mean, you basically you have trouble getting insurance. Insurance premiums are higher, and so you really don't do your patient a service when you overdiagnose melanoma either. Now, dysplastic nevi, especially on the breasts, commonly give unusual findings. They give you a little bit of pagetoid spread. They give relatively large nests, like you see in this example here. The melanocytes often have this relatively abundant fine dusty melanin in their cytoplasm. Again, this is within the range of normal in this location. So this is not a melanoma. And a lot of these we've seen and have actually done genetic testing on those. We'll talk a little bit about it later in the talk. And they come back as benign almost every time. So just remember that certain parts of the body lesions can look a little bit worse than they really are. And if you get a benign nevus that gets sunburned, like this lady that went out and did a little sunbathing and got sunburned, if you biopsy a nevus that's been sunburned, it can give you some unusual features as well. You can get some of the cells can be degenerated. You can get some pagetoid spread that usually lasts for about 6 weeks. Here's an example of one. Notice at low magnification, this is a very small lesion. It's well circumscribed. It's got all the architectural features of a benign lesion. But when you go to higher magnification, you see these irregular, funny-looking melanocytes that have this abundant melanin and some of these necrotic cells here that have probably been damaged by the sun. You get dyskeratotic keratinocytes there. So when you see dyskeratotic keratinocytes plus some inflammation, plus these melanocytes that have this sort of dusty melanin and maybe some hyperchromatic nuclei, that's within the range of normal of a lesion that's just been sunburned. So apply all the criteria, don't just look at one criteria. Now, this is another feature that we see very frequently. We get a biopsy, and if you look at a high magnification, say, gosh, there are all these melanocytes here at the junction. There's some pagetoid spread. Gosh, it sure looks like melanoma. Go back to lower magnification. Again, you see these nest of melanocytes that sort of coalesce at the dermatothermal junction, but notice the effacement of the epidermal rete here. And there's also some fibroplasia in the papillary dermis. And then we go to even lower magnification, we see some normal appearing nest of melanocytes here with a junctional component overlying it. And then at this lowest magnification, where we were looking before was over here to the left, which is an area of a recurrent or persistent nevus. This was a congenital nevus. It was an undergoing staged excision, totally benign process. When these lesions recur, they usually recur within the margin of the scar, like you see here. They're not bleeding outside the scar, like sometimes you see when you get melanoma that recurs. This occurs right over the scar, and it's confined to that area. And you usually see those funny features of pagetoid spread and the coalescence of melanocytes. They'll be localized to the area overlying the scar as well. And some people have called this pseudomelanoma. In questionable cases, try to get the previous slide if you can. Watch out for overcalling these melanoma when they're really just nevi. Now, the classic differential of Spitz's nevus and melanoma, again, the reason that these look atypical is you get mitotic figures in both, you get pagetoid spread in both, but Spitz's nevi usually have a very symmetrical appearance, so you get maturation, you get all the architectural features of a benign process. Here's a classic example of a Spitz's nevus. It's very well circumscribed, very, very symmetrical, spindle-shaped cells, some epithelioid cells as well. And there are a lot of different subtypes of Spitz's nevi. I'm not going to go into all the subtypes of Spitz's nevi in this lecture today, but there are many of these lesions now that have been looked at with genetics, and there are certain types of Spitz's nevi that give different histologic features based on the genetic mutation or the fusion protein that they have there. But this is a classic example of Spitz's nevus. And when all of these features are present, you really don't need to hedge the diagnosis and call it an atypical spitzoid lesion, only when it's got some funny features. So here's one that's got a lot of epithelioid cells. Notice that there's this irregular melanin in the lesion, so it's really not symmetrical. A lot of these nests vary in size and shape, they coalesce. So yeah, there's some epithelioid morphology of these cells. So you might say, well, it's got kind of a spitzoid morphology, but this is a spitzoid malignant melanoma. It's a malignant melanoma that's really, in my opinion, not too difficult to tell from the Spitz's nevus in this case. It sometimes can be difficult, but when you get something like that, it really shouldn't be too difficult to use. And just like this sort of rule of thumb in Spitz's nevi, in an adult, it really needs to be perfect for a Spitz's nevus, or it's more likely to be a spitzoid melanoma, or some people now are using this term atypical Spitz tumor in some cases. In a child, the reverse is true. It needs to really have every feature of melanoma, or it's pretty much more likely to be a Spitz's nevus. If you're not sure, you can cut it out. You can do some genetic testing. And we'll talk a little bit about some of these new tests we have available to us today. When I trained, we had none of these tests. We only had our eyes, and we didn't even have immunoperoxidase stains when I first started my residency program and fellowship program. We just had to basically use morphologic criteria. So I was trained as a morphologist. I'm glad that I was. I use morphology every day in my practice. I don't rely on these stains. I use them to help me, but I don't use them as the primary way to diagnosis. And we really don't use a lot of these stains in our laboratory. And I find that most people that are using these stains, they're not really confident at morphologic diagnostic criteria. And you really need to maintain your morphology, is because a lot of these stains really, they can, unfortunately, they don't rescue you. HME45, I don't think I've ever ordered HME45 and try to help me diagnose melanoma. They talk about this being more diffuse in melanoma than in nevi, but there are better tests than this today. If you want to use a test, I use genetic testing. I don't really use these tests to help me when I've got a tough case. And I just see a lot of these spitzoid lesions can demonstrate the same kind of patterns you see with a melanoma. So here's an HB45 antigen staining in melanoma. It's strongly positive diffusely, but to me, you see that sometimes in nevi. This is Ki67 staining. Of course, this correlates with mitotic figures and with proliferation in these lesions. But you can see that in Spitz's nevi, and you can see that in irritated nevi sometimes. If you're going to use one of these, this is the one I like the best. If you see loss of P16 staining in a lesion you're not sure about, or maybe it's a melanoma and a nevus, you look and you do the stain to see if you can see where the P16 is retained and where it's lost. That can maybe help in some of these cases as well, but this isn't black and white either. In my experience, you don't usually need this stain most of the time. You can usually tell with morphologic criteria, but I've seen, people use this stain, and if it's, loss in the melanoma area, you say, well, that kind of confirms the diagnosis. So it can be, of the various stains, I think this is probably the most helpful, but we really don't use it routinely in our laboratory. PRAME, I'm not a big fan of PRAME. I think it's positive spotty in nevi, and it's sometimes, it's negative in some areas of melanoma. I just don't really use it that frequently in our laboratory. A lot of guys do use it. And so it's something you can use, but, I find that really it doesn't add a whole lot to morphology in my experience. Maybe you have a nevus and a melanoma, the melanoma area will stain with the PRAME and it'll, lose the P16. And so that can kind of help you sort of distinguish, but in most cases, you really don't need it. Now, the ones that are really tough, I think that these tests are a little better. Fluorescence in situ hybridization, you're looking for abnormal expression, either aneuploidy or loss of these genes, and it's really helpful. Again, these aren't pathognomonic of malignancy, and you're looking for the percentage loss, because most cancers are aneuploid. And the idea here is that you put these fluorescent labeled probes that target these specific areas of the genome that are associated with melanoma. And so you're looking for abnormal gene fusions or aneuploidy or loss of the genes. And there are certain ones that are helpful. If you see gains in 6p25 or 11q13, especially this homozygous p21 deletion, that's a red flag for an aggressive spitzoid lesion. And again, the criteria for what somebody's atypical spitzoid lesion is not very well defined. But basically, if you see one of these lesions and you get this loss of this marker, that's really not a good finding. And here's an example of one where they use these. It's from an article where they actually use these stains. And again, it was a young child, interestingly enough, an 8-year-old boy. But if you look at the histology, it's very atypical. It's a large lesion. It clinically doesn't look like a Spitz's nevus. Histologically, it didn't look like a Spitz's nevus. So this is one that I think we would have probably been, we would call it the childhood melanoma. And it actually did end up having a homozygous P29 deletion, which was associated with a bad prognosis. Now, there's some other genetic tests you can do. You can look at array-based comparative genomic hybridization. That's looking at different areas of the genome. And again, if you take these tumor DNA and you label it with red and normal DNA with green, red plus green together should equal nothing. And so if you have too much red, that means there's too much of these abnormal genes. If you have too much green, it means there may be a loss of it. So there's a way you can actually do this and put it on a chip, and it gives you a readout. And it shows each one of these little dots is specific for a probe. Here we're looking at the 6q gene here, and this shows a deletion of that, and that's associated. That's how these things are actually read. And this was a Spitz's nevus with an 11p mutation, giving this kind of a desmoplastic morphology, which we see in certain Spitz's nevi. So a whole number of these Spitz's lesions now have been evaluated, and we're not going to talk about a lot of it in this lecture, but that's something that's very interesting, and people are beginning to look at these and using genetic abnormalities that correlate with specific morphologic findings, both clinically and histologically. Now, in some cases, if you go into these atypical lesions, we're using this test that is now the Castle. It's no longer by Myriad. Castle has acquired the Myriad test. But basically, it's looking for an expression of gene profiles that are associated with melanoma or not. And they actually have these housekeeper genes and these multifunctional immune signaling genes, et cetera. And you put these together and come up with a melanoma diagnostic score. and they have a benign malignant score and then an intermediate score. Again, we find a number of these cases do come back with the intermediate level. That unfortunately doesn't really help you, and you have to rely on what the lesion looks like clinically. We often just recommend re-excision in those cases. But in a tough case, when we get something like this, it could be extremely helpful. And there's another test now that Castle has developed using 35 genes. Again, this is, in my experience, it may be a little bit too sensitive in some cases. We're not using this still as much as we use the original test, but it is something you use in some settings. And you do have to still, be aware of over-relying on these techniques. Again, it's great when they work. It's great when you have a tough case. But when you get a case that's sort of like this one that sort of isn't really that tough, and you start putting these stains and tests on it. I mean, here's a small, symmetrical, well-circumscribed lesion with clefts, with epithelioid cells, both spindle and epithelioid. It's got epidermal hyperplasia. It's got camino bodies in it. It's got everything for a Spitz's nevus. But the other pathology group that looked at this was concerned about it, and they started testing it. And again, I would not have tested this lesion. I would have just called this a Spitz's nevus. I wouldn't have done anything else to it. And again, they did the test. They found some abnormalities with fish. They said it was a tough case. They said it was consistent with possibly a cancer. And then they ended up calling it a melanoma in a child. And they sent it to me for a second opinion and noticed it had no mitoses. So it didn't have every feature of a melanoma in a child. So you don't get childhood melanomas without mitotic figures, period, the end. So that doesn't happen. So I would not have called this a melanoma. In fact, I did not call it a melanoma. I called it Spitz's nevus. It was excised. And this is an older case. It's been about 10 years, never had any problem with it since that time. So let's now look at the opposite side of the coin, where lesions look benign, but they're really malignant. And these are the ones we get more concerned about. Again, this was a 42-year-old man seen into skin cancer screening and a suspicious mole. He went to the family physician. They did a saucerization biopsy, and this is what it looked like. It looks symmetrical at low magnification. It looks relatively small. It's well circumscribed. It's comprised of these nested melanocytes, and clearly some of these cells are nevus cells here, without doubt. But in other areas, there were more sheets of cells, and you see this ugly mitotic figure sitting in there. This was not called a melanoma. He did not get it excised. It metastasized to a lymph node, ended up getting into a medical legal case. And so this is a situation that you got to be careful of. That was a nevoid melanoma. It didn't look like a melanoma. And back in the old days, this was called minimal deviation melanoma. We don't really use that term much today, but it is something that can lead to a misdiagnosis. And so when you're looking at these tough cases, you're always worried about medical legal liability. Well, how do the lawyers, what lens do they look at when they're evaluating a med mal case, which is what they call it, med mal, which is a very important part of their practice for tort attorneys. And they use this formula that was developed by this famous judge out of New York, Judge Learned Hand, and basically look at the burden of the defendant to mitigate the risk. How serious, how big was that burden? If it's lower than the potential gravity of the loss, so in other words, the seriousness of possible developing a metastatic lesion or dying from the disease versus the probability of the harm from the defendant's conduct, if that is lower than the product of that, then you're considered to be potentially liable, that you basically were negligent, that your behavior didn't rise to the standard of care that it should have. So that's something to remember. If your burden to prevent the harm is low and you don't act, you are at risk. And so if you don't order a special stain, if you don't order one of these tests, if you don't send clinical photos, you don't make recommendations, et cetera, put all that together. You don't want to overdo it. Again, if your burden is too high, obviously you don't want to stain every potential lesion. But on the other hand, if it's a tough case, you don't want to just sort of slough it off. So just remember that when you're thinking about these. Another tough case, blue nevus-like melanoma. These are commonly misdiagnosed as a cellular or combined blue nevi. They often look symmetrical. They're often vertically oriented. They may look like a blue nevus clinically. This was a 25-year-old woman. They did a punch biopsy, which unfortunately hinders your ability to evaluate breadth, symmetry, circumscription. It seems vertically oriented. There's not much epidermal involvement, but has some pleomorphism of these cells here and had a mitotic figure. And this was recognized. It was excised. Unfortunately, she developed a lymph node metastasis from this. I don't know that she passed away from it, but she did get metastatic disease. Sometimes we see poorly differentiated spindle cell neoplasms. These classically include melanoma, squamous cell, and atypical fibroxanthoma. These you have to stain, you have to work these up. This is one that's obviously malignant here. Again, you look at it, this was positive for HME45 antigen, so it was a malignant melanoma. Another one is poorly differentiated spindle cell lesion, positive for CD10. So this was an atypical fibroxanthoma. And the last one, poorly differentiated, was positive cytokeratin. So just remember those three sort of bad actors, if you will. They can all look alike, and you don't want to miss a melanoma and call it a squamous cell. I've seen lawsuits spawned in that situation. Here's another case we had a number of years ago. This is a lesion that was sent in as rule-out squamous cell carcinoma. It looks like a squamous cell carcinoma. It's got this verrucous epithelial hyperplasia with atypia. It's got the keratin pearls down there, and it's got this poorly differentiated area in the center. And so you might say, well, that looks a lot like a poorly differentiated squamous cell carcinoma. Let's just call it that and move on and excise it. Well, we didn't do that. We actually said, let's work that up and just make 100% sure that it is squamous cell. This is what the lesion looked like clinically. You can see it's got some areas of pigment in there. That could be hemorrhage, a lot of sun damage in the background. Well, this is a cytokeratin stain highlighting all those keratin areas. And notice that the central areas were not staining. Those were highlighted with S100 protein. So this was an example of a verrucous malignant melanoma. Vastly different prognosis than a squamous cell carcinoma. So don't miss the diagnosis of melanoma and call it a squamous cell. That's not good either. And then last of all, of course, we get desmoplastic malignant melanoma. This is a very dangerous lesion, commonly missed. Most of the time it's S100 protein positive, but not always. SOX10 is a good marker for this. Another example, again, notice this is a very, if you look at this low magnification, it really is very bland. The cells don't look very atypical. It looks like a neurofibroma. It's got a fibromucinous stroma. It really doesn't have a lot of atypia of any of these cells in here. And lo and behold, in this one area, it had one focus where there was the overlying melanoma in situ. The dermal, pure desmoplastic melanomas, those can be very difficult to diagnose. You need to have a high index of suspicion and just remember them. These lesions don't look like melanoma. Look at this lesion on this guy's scalp. It looks like an actinic keratosis, and it turned out to be desmoplastic melanoma. So this is really something that can be very difficult to diagnose and problematic, medically very charged. Now, a lot of surgeons will do immunoperoxidase stains to try to determine their surgical marks for melanoma in situ and sun damaged skin. It's not a necessarily unreasonable way to go. When you've got something like this, you know this person's going to have, you're going to have a difficulty determining where that melanoma may come to an end. The problem with doing these stains, and here you see the melanoma in situ here that was positive for the S100 protein here, HMB45 antigen, but this is a solar lentigo. And notice this is not a melanocytic lesion, but it still highlights with those same markers. And so when you're putting these side by side and you're dealing with somebody that's got all this solar lentiginous around their melanoma in situ, you'll be cutting and cutting and cutting and cutting forever. So that can be a problem, and you can do too much surgery. So what's a way to kind of get around that? Well, the way we like to do it is do a Woods lamp examination, which will highlight subclinical pigment like the B photograph you see over there, excise around that area, and you're much less likely to get into problems with this overcutting by just doing these stains. So you've got to be careful using those stains to determine melanoma in situ and sun damaged skin. So last thing is talk a little bit about our nail melanocytic lesions. These are not for the faint of heart. If you don't have experience with this, you shouldn't get into this field. You need to really have good experience doing this. If you're going to take a nail unit biopsy, you need to get into the matrix. You need to reflect back the nail fold and get into the matrix. This guy missed the matrix. So this might not even show any melanocytic lesion here. You've got to get into the matrix when you're biopsying one of these lesions. This is a benign pigmented band of the nail unit, totally benign. Biopsy here just shows some slight hyperpigmentation with a few little dendritic melanocytes. Notice the dendritic melanocytes don't extend beyond the basal cell layer, more than about 1 or 2 cell layers up. And here you can see that with this Fontana-Masson stain. If they start getting throughout the epithelium, that's a sign you're dealing with early melanoma in situ. This is melanoma from the nail unit. And notice that even though it's an obvious clinical melanoma, it looks relatively bland histologically. So these things can look worse clinically than they do histologically. You have to have a high index of suspicion. I encourage my clinicians to send me clinical photographs of nail unit biopsies when they do them. Notice here you can see these dendrites extending throughout the epithelium with this S100 protein stain. And so just remember that as when you're looking at nail unit lesions. So just a couple other things briefly, histologic reporting of surgical margins for melanoma. Just remember that basically there's no data to suggest that you need to measure a melanoma and talk about how far it goes to the edges. That's really a clinical determination. These syntopic reports, I don't like them because they tend to make things look they're good for research, but be careful. You want to make sure that you get the diagnosis right. I've seen wrong diagnoses look right because they're syntopically reported. Prognostication, again, AJCC likes to use the AJCC criteria. Again, these can be problematic. Ulceration in thin melanomas, almost never seen. Mitoses, again, can be problematic because you can see big, thick melanomas like this with few mitotic figures, and then thin melanomas with mitotic figures, and even epidermal mitoses. Nobody knows what to do with those. And we really don't see very many mitotic figures in thin melanomas, very few in thin melanomas. Regression, if it's complete confluent regression, that's important. A case like this patient that had a metastatic lesion, had a primary lesion that had totally regressed, that's important. But getting partial regression in a melanoma like something like this, we're not sure what that means. Some papers show that it's more likely to be a good prognosis, others less prognosis. I always like to say that the microscope is not really a crystal ball. You actually can now prognosticate using the Castle prognostication test. We find this to be a very useful test in our laboratory. Basically, and this is looking at a lot of things other than melanoma genes. It kind of gives you a holistic view of the melanoma-host interaction. It's being used now routinely in uveal melanoma, much more routinely now in cutaneous melanoma. Many studies have shown that this is repeatable with prospective and retrospective studies where you get this Kaplan-Meier curve that shows that there's a distinction between these class 1 and class 2 lesions. It's about 10 times more accurate than AJCC. It's more accurate than sentinel lymph node status. Again, you can see the sentinel lymph node status is better than nothing, but it's not even as good as the genetic profile on the primary lesion. And these are just 3 examples that the Castle case reported. Again, thin lesions in 2 patients. One guy was class 2, did poorly. Class 1 did well. That's rare to see that. This is really the best use of it is in intermediate thickness melanomas. And then the one where it's, again, in very thick melanomas, if you get a class 1 result that's thick, that's good news for the patient. So all those things are helpful. And these are being incorporated into melanoma sort of protocols, if you will, at universities around the United States. So many new advances in melanoma diagnosis and therapy. Again, you really need to use your morphology. Don't forget about those. These tests are helpful, but you really need to rely on your morphology. These are my 2 little grandkids, and we've got another one on the way, I'm happy to say. So thank you for your attention and hope this was valuable for you.